So good morning, everybody, and welcome to the latest in our round of Fungisphere talks. We're very pleased today to welcome Jana, who is a senior scientist from St. Vincent's Hospital here in Sydney. St. Vincent's is where they do a lot of therapeutic drug monitoring for antifungal agents, and Jana, who I've heard speaking about this before, has got a lot of passion for therapeutic drug monitoring. So we're really looking forward to hearing from you, Jana. I will let you complete introduction of yourself if there's anything else you wanted to add, and then just let rip with your talk. So thank you very much for joining us this morning.
Thanks so much, Justin. I'm just really grateful for the opportunity to present today. I really love the Fungisphere group. I had a little look at, all the different things that you guys do, and I love to see the interdisciplinarity and, just a wide range of quite exciting research happening. So today I'd like to talk about a drug interaction that I find particularly interesting, where if we took a little deeper look, we find that some features that I think that make it a really unique interaction. I particularly like this example because it teaches us new things about new drugs, and it teaches us new things about how drug interactions work, despite involving a drug that has been available for decades. So that would be fluvoxacillin, which has been available since the 70s. So when I was putting this talk together, I noticed that groups of 4 kept popping up. So I decided to take the Fab 4 as a theme to carry through the presentation, and you'll see them popping up along the way. I'm mindful there's a diversity of disciplines in the Fungisphere community, so I'm going to cover some basic concepts that, just to start with. We know that dose is related to effect, and that the piece in the middle is the systemic concentration available to act at the site of drug action. Free concentrations in plasma tend to be related to the concentration at the target site, so this can be useful information. Pharmacokinetics describes the relationship between drug dose and systemic concentration, typically concentrations in plasma, and pharmacodynamics describes the relationship between drug dose and it relates concentration with drug effects. For antimicrobial drugs, the concentration required for effect is conveniently related to the microorganism's minimum inhibitory concentration. Systemic concentrations can be plotted over time in a concentration time curve. This curve shows an initial oral dose that takes some time to be absorbed, reaching a maximum concentration, lowering as the drug is eliminated from the body. The area under the concentration time curve is considered a useful indicator for exposure and tends to relate to the final effect. The concentration towards the end of the dosing interval is the trough concentration, and we have the concept of the therapeutic range defined by a minimum concentration for effect and a minimum concentration before toxicity appears. What I want to show with this very simple slide is that for some drugs, despite a single same dose, a very different systemic concentration can be achieved. And although I don't have data to show this, believe me, this can also happen in animals on a drug by drug basis for specific drugs, which has implications in experimental work as well. So pharmacokinetics involve 4 main processes that affect the final concentration available to act. These are absorption, metabolism, distribution, and excretion. For an oral formulation, absorption can lead to a variability depending on the drug, for example, due to differences in, say, something like stomach pH. Metabolism is a process typically involving lipophilic drugs that render them more hydrophilic in order to be eliminated. The enzymes and transporters involved in this can harbor genetic polymorphisms that can affect their efficacy, contributing to the variability that we might observe in concentration. Also, both endogenous and exogenous compounds are substrates of these enzymes and transporters, further contributing to the variability of systemic concentrations in drugs that are involved in these pathways. Distribution refers to how the drugs spread throughout the body, and some drugs are confined to the fluid space while others penetrate into tissue. Transporters can be imported for tissue penetration, and again, this can have genetic differences in the concentrations observed. Some drugs bind to plasma proteins, which is important as only the free drug concentration influences the final effect. And finally, we have excretion, which is predominantly through urine, either as a parent drug or metabolite. And excretion can also be through bile and feces as well. So this is just an overview, but I just wanted to highlight that these processes can vary a lot across drugs, and we will see that with the azoles. So here we have our first Fab4 example: absorption, distribution, metabolism, and excretion. All these influence the concentration that is available for drug action. So I'll just touch on therapeutic drug monitoring, again, mindful that many of you are clinical people, which are very familiar with this. For the certain drugs, we measure concentrations and adapt their dosage to achieve an optimum concentration for efficacy and avoid adverse effects. We tend to do this with drugs that exhibit large interpatient variability in plasma concentrations for a given dose. It may be especially important for drugs that have a narrow therapeutic window, where concentration for efficacy is close to the concentration where toxicity is observed. In order to aim for a target range, it's really important that an established relationship between plasma concentration and effects is available. And it's especially useful to do this when dose optimization is not possible with available clinical observation or tests. Finally, it's important to note that this is not a straightforward process and typically involves a service and multiple steps and multiple people. So this illustrates some of those steps. We start by collecting a drug sample from the patient. Typically, this is a trough concentration immediately before the next dose is due. The timing of this is really important for interpretation of the result, and poor timing is a major challenge in conducting TDM well. Drugs are measured by two predominant methods, either immunoassay, and this is common for the classic TDM drugs such as vancomycin, aminoglycosides, and immunosuppressants. Immunoassays are available widely, so most larger hospitals in Australia would have tests available. The mass spec-based assays tend to be for more recent TDM candidate drugs, including the azole antifungals, beta-lactams, linezolid, among others. These tend to be available at specialised centres, and we're very lucky at St Vincent's to have a long history of assays based on chromatographic methods. The concentration that is measured can be used in Bayesian forecasting. Often this is used to determine the AUC from a single measurement, but can also involve multiple samples for some drugs. For some drugs, this is necessary, and typically this is established by an established limited sampling strategy. In practice, this is primarily used in a widespread way. The obvious example is vancomycin. We use the AUC to then relate it to the minimum inhibitory concentration, and AUC-based monitoring has happened really in the last decade with evidence to show that it optimizes efficacy while reducing nephrotoxicity, which is the main one of the main adverse effects, compared to just measuring trough concentration alone. Finally, TDM can involve multiple professionals, including clinicians, nurses, phlebotomists, analytical chemists, and pharmacists. So it's a big, long process, big, happy family. We'll just delve in a little bit more into metabolism. This is just to illustrate what can happen to the drug in a metabolic setting. Enzymes are involved in biotransformation of drugs, but transporters influence the process by allowing what concentrations are available to be metabolized. Drugs undergo phase 1 metabolism, predominantly involving the CYP450 system. The transformations include hydroxylation and methylation. And in general, this either makes the drug more water soluble to enhance elimination directly, or more reactive to then be transformed by phase 2, which typically involves an adduct that is water soluble to enhance elimination. So the CYP450 system is a large system of enzymes with multiple isoforms. However, only certain isoforms are predominantly involved in drug metabolism, and we'll focus on 3A4, 2C9, and 2C19 in this talk. Jana, so again, Fab4, yes?
Sorry.
Yes.
Just the way the slides are presented, they're a little bit small. Is it possible to change the way that you're sharing?
Oh, yes. Let me try. Let me just try that. Just give me a tick. Thanks for letting me know about that. I've just got a single screen, and I've got my, you know how you've got your PowerPoint and then the notes.
Yeah, I know
so
exactly.
That's what's making it a little bit tricky, but let me just
that looks
see.
Way better.
Is that better? Great.
Yes, thanks so much.
Great. Thanks, guys, and apologies for that. So Fab4, just find my place. So the first So I've mentioned this before. Many of the enzymes exhibit genetic
Oh,
polymorphisms.
Jana,
Yes.
I'm sorry.
Yes.
Now it's cutting part of the slide off. Sorry, I don't really know how it works on Apple. So
On my end. Yeah, sure thing. Gosh.
right now we can
Okay.
see everything.
All right. Okay. Let's see. Let's see if I can do this. Okay. Thanks. Apologies, everyone. I haven't practiced with the notes in this before, and just to get my head around it. Anyway, that's all right. We'll keep going. So back to genetic polymorphisms, and while the different isoforms that we saw before have are polymorphic, I just picked these 4 examples to illustrate polymorphisms that have different functional effects, but that are also very, very common. So while CYP2C9 and 2C19 are actually particularly polymorphic, so there's many, many more polymorphisms than the ones here, but again, these ones are the ones that are quite common. We have the most common ones presented here. CYP2C9 has 2 common alleles, which render the enzyme less effective. These cause an amino acid change, and the activity of the enzyme is substantially reduced. Particularly the START2 allele is quite common in Caucasian populations. I love the 2C19 polymorphisms because these are quite unusual. So the START2 allele in this case results in a splicing defect in one of the introns, which ultimately results in decreased enzyme function, while the STAR17 polymorphism is located in the promoter region. This could cause an increase of transcription, and we see augmented function in people that carry this polymorphism. The STAR17 reflects the fact that this polymorphism was only quite recently discovered and named and annotated. Just to note that there is a dose effect with polymorphisms. For example, in a study that we did with voriconazole, metabolized by 2C19, we found 3 of 60 individuals that carried both STAR2 and STAR17, which makes it really difficult to predict the final effect. So it's quite helpful to be able to measure drug concentration. Another cause of variation is drug interactions. So many drugs are substrates of these enzymes and transporter. Here I've listed some typical examples. However, the list for some of these enzymes is quite long. Note that concomitantly taken drugs can act as an inhibitor or an inducer. There are many inhibitors, especially for 3A4 and 2C9, and then gene inductions of these enzymes is possible, and the classic inducers are rifampicin, carbamazepine, phenytoin, and St. John's wort. So we'll get to our antifungal Fab4. Antifungals work by impairing ergosterol synthesis in the fungal cell membrane, leading to their breakdown, and inhibit sterol demethylase enzymes, namely the CYP51 enzyme system. These, as you can imagine, have similarities to the CYPs we mentioned, but are not expressed in humans. And azole antifungals are typically used to treat as treatment and prophylaxis of invasive fungal infections. Since their introduction, azoles have greatly contributed to our therapeutic options. A particularly handy thing is that the availability of oral formulations for these drugs, where other important classes used for serious infections typically have just IV options available. They have tended to have fewer adverse effects compared to the earlier antifungals. Fluconazole and itraconazole were introduced in the 90s, and voriconazole in the early 2000s, while posaconazole was introduced in 2006. It's important to note that drug companies, especially in the case of voriconazole, initially promoted that concentration monitoring was not necessary. However, as I mentioned earlier at St. Vincent's, we've been lucky to have these assays since the mid-2000s. While posaconazole was introduced in 2006, we now have a slow-release tablet formulation, improving the absorption. And I missed one, which is isoviconazole, so that can be Stuart Sutcliffe, the bass player before John Lennon. I won't refer to it much. We tend to reserve it for resistance of infections and don't use it too often. So here we have our Fab4. It's a little bit overwhelming, but what I want to show here is that despite being a class of drugs, the individual drugs have very, very, very different pharmacokinetic profiles. So starting with absorption, we've got very good oral bioavailability for fluconazole and voriconazole. However, it's more complex for itraconazole and posaconazole. There have been some improvements with these formulations that I mentioned, with posaconazole, the tablet, and a newer brand of tablets for itraconazole called Lozenox. And notably, itraconazole absorption is enhanced by acidic stomach pH, particularly for the earlier formulations. So with regard to distributions, we see differences in tissue penetration. Flucloxacillin and voriconazole exhibit quite good penetration, while the other two do not. We also see a range in protein binding, in particular itraconazole, and itraconazole and posaconazole exhibit extremely high protein binding. These drugs typically tend to have long half-lives, but exhibit vast patient variability in this parameter as well. In terms of metabolism, fluconazole is not a substrate of the CYP450 enzymes. However, it is an inhibitor. The other drugs are predominantly metabolized by unique enzymes across the agents. So itraconazole is predominantly metabolized by 3A4, with transformation producing an active metabolite. Voriconazole predominantly by 2C19, although 2C9 plays a role, with 3A4 a little bit less. And posaconazole undergoes phase 2 metabolism predominantly, resulting in an inactive metabolite. It's important to mention that voriconazole has nonlinear pharmacokinetics, which means that concentrations can increase more than proportionately with an increase in dose. This is likely attributed to saturation of hepatic metabolism. For excretion, again, we see substantial differences. Itraconazole undergoes enterohepatic recirculation, possibly suggesting an involvement of microbiota in its pharmacokinetics. We also see differences in excretion, whether it's excreted in urine or with bile, in bile as well. Here we see the predominant enzymes affecting these drugs. The thing to note here is that these drugs are substrates and inhibitors often of the same enzyme. Another thing to note is that they're all inhibitors of CYP3A4. So I chose Yoko Ono to represent our interacting drug flucloxacillin. So flucloxacillin is a narrow spectrum penicillin with anti-staphylococcus activity. It's stable to beta-lactamase enzymes produced by staphylococci, including MSSA. It has reasonable oral absorption and substantial protein binding. The primary route of elimination is by the kidneys, and a small proportion is metabolized. However, it's not considered a significant substrate or inhibitor of CYP450 enzymes. The half-life is very short, so frequent daily dosing is typically required for intermittent dosing, and the oral dosing maximum by recommendations is 4 grams, and then you would pass on to IV formulations. So now I've come to this really interesting interaction between flucloxacillin and voriconazole. It was first described by a group in in South Australia in 2015. And then we had some case series, first from a Dutch group and then from a Belgian group. So the initial report was a single case. So this was a person taking a low dose prednisolone for polymyalgia rheumatica. This resulted in a S-apiospermum infection involving the skin, lungs, and brain. It was well controlled with voriconazole prior to starting flucloxacillin. However, when flucloxacillin was started, clinical relapse occurred with new skin lesions, and the voriconazole concentrations were found to be subtherapeutic. This was really unexpected, and the authors put forward that flucloxacillin might be activating the PXR nuclear receptor, which in turn induces transcription of numerous CYP450 enzymes. And there had been some reports to that date, with data to show that CYP3A4 and 2C9 and 8 were affected by flucloxacillin, or alternatively decloxacillin. In the DO 2013 report, there was some evidence that induction depended on PXR polymorphism. So that's another aspect that might explain patient variability in what is observed with regard to this interaction. And Kennedy and colleagues also noted a hard to find Congress abstract from 1999 that showed that flucloxacillin affects cyclosporin concentrations when they are used together, reducing cyclosporin concentrations by about 50%. So the next report was a case series where a strong effect by flucloxacillin on voriconazole was noted in 11 of 20 people. These people had concentration below the 1 milligram per liter therapeutic threshold. However, not many people achieved above 2 grams as well. So a drop was noted in most people. The authors recommended to avoid the combination. A more recent report with 33 cases, the authors performed a multi-variable analysis this time. They showed that high initial voriconazole concentrations, so they showed that flucloxacillin co-administration is indeed associated with voriconazole concentrations. This is like it might seem unusual, but on the grapevine this interaction is discussed, and people don't really believe it. So this particular paper sort of consolidated that this really is a phenomenon. So high initial voriconazole concentrations and concomitantly taken proton pump inhibitors, which inhibit 2C19, associated with higher voriconazole concentrations. And an interesting finding was that orally taking flucloxacillin was associated with lower concentrations, which requires confirmations. But some experimental work has failed to show a dose-dependent PXR activation by flucloxacillin. So is this really a PXR mediated induction? So this earlier report from the Dutch group, they argued that PXR mediated induction is really unlikely. So they note that the time course of onset of a change in concentration and after cessation is much faster compared to typical inducers, such as the ones I've mentioned. Voriconazole peak concentrations in their set for some patients, so that was the 11 of 20, were very low and sometimes even undetectable. So this is again unusual because when we see this induction, it takes about 2 weeks, 2 to 3 weeks to see it, and then the effect on the drug that's being affected is like a 50%, typically something like a 50% change in AUC. The concentrations of other CYP3A4 substrates appeared to remain unaffected. They didn't provide much detail about this, but I presume that they were referring to the calcineurin inhibitors, which is another drug that typically gets monitored and concentrations are measured. However, only 2 of the 20 patients were taking an immunosuppressant, and they didn't really comment on dose. It's possible that the dose was adjusted and the concentrations remained the same. So other arguments, could this be an artifact of CRP elevation prior to flucloxacillin? So the die-hard denialists about this interaction think that what we might be seeing is that CRP prior to starting, an elevation in CRP, well, we know that it affects voriconazole concentrations by increasing them when it's really high. So starting flucloxacillin reduces CRP, and perhaps we're seeing a reduction, like an immediate reduction, but that doesn't really explain the very dramatic drop in voriconazole concentrations. So what about immunosuppressants on their own? This is that hard to find abstract from a Congress presentation that I referred to earlier. And again, just to show that CSA trough levels fell by 55%. And I would say that this is the only example that is sort of out there that implies that induction is happening with flucloxacillin in one of the sort of databases that we might use. So this particular interaction is in Stockley's drug interactions, but it's not mentioned sort of anywhere else. More recently, we've seen a case series of immunosuppressant drug interactions with flucloxacillin in heart transplant recipients. Just the really important thing to note here is that in all 4 cases, we saw rejection episodes. So this was a clinically significant interaction. Just note that we are increasing the dose for most of these. And as you can see, the concentration of, in particular, tacrolimus follows with a dose tends to follow with a dose increase, which is not the case for some people with voriconazole. So you could give them bucket loads of voriconazole and still not elevate that low concentration. So flucloxacillin, this is another report from a Dutch group this time, and again showing the same, that tacrolimus is affected while flucloxacillin is taken. Note that the y-axis is actually concentrations normalized by the dose. So you might not see changes in concentrations, but yes, something is happening. Doses are being increased. So this is our data. We took a look at 3-way interactions in people that were having flucloxacillin, voriconazole, and tacrolimus to see if it is true. The previous paper that I mentioned with the 2 patients that were transplant patients and no difference was seen in their concentration, the authors argued, well, because voriconazole inhibits tacrolimus removal, perhaps it's less likely to be affected in the situation where it's together with voriconazole, so the 3 together. We found that that wasn't the case. Tacrolimus is affected even in the context of voriconazole as an inhibitor. So we had 3 of 8 patients that had concentrations measured prior to flucloxacillin. All had been therapeutic prior. 8 of the 8 patients had subtherapeutic concentrations while they were on flucloxacillin for voriconazole. 5 of these exhibited subtherapeutic concentrations despite voriconazole dose increases. Speaking to that point that I made before, you just keep adding and nothing happens. And so 2 patients were changed to alternative antifungal agents. With regard to tacrolimus, supratherapeutic tacrolimus concentration was found in 7 of 8 patients following flucloxacillin discontinuations. That's highlighting really the main difficulty in managing this. So we were able to maintain concentration over the course of flucloxacillin treatment, but once it stopped, it was just very difficult. Our concentrations for tacrolimus went all over the place, and dose increase was required for all these patients, for the tacrolimus patients, while they were taking flucloxacillin. So how do classic inducers affect voriconazole? So the classic inducers is noted actually in the product information. So they've got a few early studies on this, but I just really want to make the point that these were all healthy volunteers in all these instances. So rifabutin and rifampicin decreased voriconazole Cmax and AUC. Phenytoin likewise, the effect was, as I mentioned, something like 50% reduction, nothing like the dramatic drop to very low concentrations that do not respond to increased dosing. And also interesting to note is that for St. John's wort, there was a reduction on voriconazole AUC that only occurred on day 15. So again, confirming what we know about drug induction, that it takes about 2 weeks to be effective. However, there have been some reports as well, just highlighting this issue of very low trough concentration effects on Cmax and AUC that are dramatic. Doubling the dose increases did not achieve adequate exposure. So again, a very unique feature of this interaction. So is voriconazole the only azole affected by flucloxacillin? And very recent reports suggest that it isn't. This is just an initial report, which they show that it's the initial phase of isovuconazole initiation, which of course takes time to achieve steady state and so on, but it does appear to have an effect on the isovuconazole concentrations. And then we have posaconazole, which I guess is unexpected, particularly because it's more of a phase 2, goes through phase 2 metabolism. However, PGP is affected by PXR induction, so the mechanisms here remain to be elucidated. Again, we see a massive drop with voriconazole, so that's the very first dashed diagonal line, and posaconazole is the one that I've highlighted in yellow. And for both voriconazole and posaconazole, the one represents sort of the therapeutic threshold. And we see that with a posaconazole, it drops below. I would like to have more information about posaconazole, and we're actually going to go back and look through our cases to see if we see if this really is an effect for posaconazole. But it's interesting, given that it's a substrate of different enzymes and transporters. So here we have another case series from our institution. The first case is a 64-year-old man that had CNS lymphoma, had undergone chemotherapy, and then presented with febrile neutropenia. Blood cultures showed MSSA sensitive to flucloxacillin, and 2 grams 4 times a day was started. He had been taking the Sporanox brand of itraconazole at 200 milligrams twice a day that had been started about 3 months prior, and you see a drop in the concentration in the phase where flucloxacillin was used. The next case is a 67-year-old lady who had been a bone marrow transplant. She was receiving tacrolimus because she had graft versus host disease. She presented with febrile neutropenia. Again, MSSA was detected in blood cultures. I think she was managed as an outpatient with oral flucloxacillin, 1 gram 4 times a day. The levels were low, and I think she wasn't clearing the cultures, and that she was brought into hospital and was started IV intravenous flucloxacillin at 2 grams 4 times a day. And again, the flucloxacillin levels, we measured them, not everyone measures them, they were low, so she was changed to 14 grams continuous infusion. So she had been on itraconazole long-term with levels in the sort of therapeutic range. And then with flucloxacillin, we see a drop, and that followed in the period afterwards for some time until it came back up. And our last case is a 22-year-old lung transplant recipient who had CF. Again, was started flucloxacillin 2 grams 4 times a day. She had only really just started itraconazole, so in a sense, her levels are rising, reflecting a recent commencement. However, even with a dose increase of 250 milligrams twice a day at that second little cross indicated on the slide, she failed to increase the itraconazole levels and was started on posaconazole. This sort of started at this point, and we didn't really have any levels to have a look at what happened to posaconazole in the initial phase. But after stopping flucloxacillin, she achieved good posaconazole concentrations. And continued to so intriguing. Flucloxacillin was not really considered a classic inducer. And again, people still continue to debate the point of whether really it is inducing these the metabolism of these drugs. There's growing evidence for PXR activation, including some rapid onset scenario. So this is unusual compared to other inducers, typically within 7 days, and it can be even shorter for some. But again, we have those examples of the classic inducers with a very high drop in concentrations with phenytoin as well. So there might be something happening in people that are particularly unwell, which I touched on before. So the effect on voriconazole concentrations can be dramatic. They go very low. They don't respond to dose increase. In the case of voriconazole especially, not all patients are affected. So perhaps genetic polymorphisms in CYP2C19 with the STAR17 polymorphism that I mentioned is a possibility. It is involved in transcription and therefore might be the reason why we're seeing this in the scenario of having a transcription factor like PXR inducing the expression of this gene. But it could also be related to genetic polymorphisms in NR1I2, which is the PXR gene. But just to note that of the phenytoin cases I presented earlier, only one was genotyped and was not found to carry this star17 polymorphism. So again, this interaction is still not included in medications-related databases. I find that among the hospital community, people are picking it up and it's sort of on the radar, and people are aware of it, avoiding especially the combination of voriconazole and flucloxacillin. However, I'm mindful that it's not out there, and I'm particularly sort of concerned about the outpatient setting, especially in the context of not being supported by the product information and these databases, given that it can have such dramatic effects. So I'll just end it there, but I'll also point out that we've started a podcast project with my friend there, Florian Lamette. He's on the far side, and this is with the ITDMCT, the International Association of Therapeutic Drug Monitoring. So that kind of brings together why I touched on the Beatles, and you can hear this on any of your favorite podcast platforms. And we basically just talk about our love for TDM. So Justin was right, I'm a big fan. So thanks very much.
Thank you so much, Jana. That was really, really great. Super interesting. I'm never going to be able to look at flucloxacillin and voriconazole without thinking of Yoko Ono and John Lennon now. So good work. Good work on that. It's really important to be cognizant of those interactions, given that people are generally taking antifungals for ages, and obviously flucloxacillin is one of the commonest drugs that we would be using. So it's important that people are aware of that. So thank you.
You're welcome.
Does anybody have any questions for Jana? Okay, the room of Mawson Wang, we have a raised hand. Who's got a question?
It's my hand, Justin. Jan Willem here.
Oh, Jan
Oh
Willem.
no!
Hello.
I was looking at you in the participants list. Oh man!
Thank you, Jana, for
so
your
most
talk.
of those publications, Jan Willem is a co-author.
Yeah,
So that's a bit embarrassing.
So I had a question, Jana. With all this data, do you think there's a need to do a proper drug interaction study, randomized, crossover, etc., to really convince those who do not believe
I'll
in
answer
this
your
interaction?
question with a question. Are we going to be able to do this drug interaction in really sick patients? Is that ethically reasonable?
Why do you
It
want
seems to be
really
an
sick
issue.
patients?
It seems to be an issue with really sick patients, especially with the product information of voriconazole. With the data from healthy subjects, the behavior was quite similar to what you expect from an induction scenario. And so I think that's one part to it. But I guess, the point, yes, you can. Yes, please, let's do this drug interaction study. But I fear that if we use normal subjects, we wouldn't see such a dramatic effect. And the point is that in sick patients, it's very dramatic.
So does that mean that the mechanism of interaction is different then?
I just think there's a lot of interesting things going on. We need to sit down and have a chat about this because this was just recently published, right? So another one on the ID Twitter that's been sort of a point made about, piperacillin, piptaz, that with VANC, that is a pseudo toxicity, right? And then a recent publication, I think it was a sub study or a small part of the Camera 2 trial. My friend Amy Legg was leading that publication. So she did this big multivariate analysis with quite good prospective data to implicate flucloxacillin in nephrotoxicity from vancomycin. And again, the classic pharmacologists come in and they say, yeah, but nah. But the thing is, we look deeper, and so just even with PXR, right? So with PXR, PXR will jump onto the trans-3A4, some of the other CYP enzymes. However, it pulls activation factors for that from the transcription of the transporters. something's happening here, and I think inflammation has a role in that. And you're the big brain in the inflammation influencing pharmacokinetic space. So let's keep talking.
Thank you.
Who's next? I think, Caitlin, you're talking, but you're muted.
Yeah. I am. A directly relevant question, but I'm excited about your podcast, Jana, and I've just signed up to listen to it. That's amazing. I've got a tangential question, and feel free to just say that's a complete tangent. But itraconazole versus posaconazole for candida, and again, you might not have anything to do with this, but the clinical break or the ECOFs, often itraconazole sits under it while posaconazole doesn't, and I've always thought of posaconazole as a broader agent. Have you got any comments on that?
I'm really don't have any sense for the spectrum of activity, but I found the pharmacokinetics fascinating. We're just taking a look at our fact sheets. So a lot of people, I mean, there's other places offering the assays, but we're just updating our fact sheets. I'll have a chat to you about this anyway, because I think it's what we consider effective concentrations and
Thank you.
So forth.
Do you have any other questions for Jana? Feel free to unmute yourself or raise your hand if you're shy. No, then I think we're pretty good. So, Jana, thank you very much for joining today and giving that fantastic talk. It was really interesting. And we'll be posting this onto our YouTube channel shortly. So, thanks.